Many countries, including Britain, are experiencing a rapid ageing of their populations. By 2021, 20% of the urban population and 29% of the rural population will be over the age of 65. More than 1 in 12 people in the UK will be aged over 80 by 2039, and the UK's population is set to rise by 4.4 million in the next decade. Both academic research and anecdotal evidence has shown that staying in your home into old age can improve health and well-being and reduce the need for medical intervention. The true impact of this ageing population on health and social care services is becoming increasingly hard to predict. It may lead to significant cost burdens for the rest of society, or it may create new economic and social opportunities. Either way, the increase has triggered concern over how the world will cope in the future, particularly with greater demand on healthcare provision. At a time when the public purse is under severe pressure, what can the engineering community do to ensure that homes, public transport and infrastructure can cope with the growing demands from our older population? Mr. Chairman, ladies and gentlemen, I would like to take this opportunity to offer you a warm welcome on behalf of the Institution of Mechanical Engineers here at the headquarters at Birdcage Walk. For this, the 2017 Global Engineering Debate on Healthcare for an Ageing Population, organised by the IMechE's Young Members Board. I would now like to invite the Chairman, Garth Johnson, who is the Emeritus Professor of Rehabilitation Engineering at the University of Newcastle and Fellow of both the Royal Academy of Engineering and the IMechE, to lead this debate. So thank you very much.
I'm then going to speak to you for a few minutes about some background information about that, and then we shall proceed. Our speakers will come to the platform. We'll move on with their presentations and the debate. So let's look the debate question. These answers will be counted, and we take this vote now before anybody has made any other comments or statements about the field. So this is the initial data. If you like, this is a drug trial. It's before you've had any drugs inside you, of people talking to you. This is the initial data that we take. So please, can you vote now accordingly? These are some thoughts about priorities. They're not, I don't think will influence you in the sense of what the exact question is, but I think there are some things we ought to be aware of and have in our minds. So engineers, and we're going to hear about this today, can provide solutions to almost any problem. We're the clever people who can solve problems for the population. But what are we trying to achieve? Are we trying to allow people to live longer? Do we want them to keep active longer? Do we want to reduce the number of people in hospital and address those difficult problems of bed blocking? Do we want to increase or reduce the number of care homes? Do we want to automate care processes? These are all the sorts of things you might want to think about in the question. And the thing to remember at the bottom of all this is everybody, if you question them, always want to live at home if it's at all possible. So Helen's already hinted to you about the demographic changes, and you see the red line is where we are now, and these are the increases in projections of older adults right through to the year 2039 with this inexorable increase, and in particular you'll notice the 90 pluses who keep on increasing. Perhaps the number that really matters is the old age dependency ratio, and that's a ratio of the number of people who draw pensions to the number of people who draw salaries or wages. And that's what those data look like. So the bigger that ratio, the more it's costing the state, the more the taxes you're going to have to pay. You'll notice some discontinuities in there, and that's when governments decide that they're going to change the pension age. The social care cost, these are the sorts of numbers we're talking about in billions. 17 billion is the total social care cost at current information 2015-16. So what's long life like? Is it healthy or is it unhealthy? And it's the healthy life years that matter. At the moment, on current data, a man will have 10.5 years free from disability from the age of 65, and then probably another 7.5 years with some disabilities. The figures for women are slightly better. They will have 11 years disability free, then with another nearly 10 years through to the end of life. But those are the numbers that we'd love to be able to influence. So, how do we keep people independent? They've got to be able to do the real necessary things of life. They've got to be able to do their cooking. They've got to be able to use the toilets. They've got to be able to wash themselves, do the shopping, and communicate with their neighbours and friends. So some work you can do, and I don't want to go into any detail of that, we can actually calibrate the way people decline in ageing by looking at this set of what we call ADLs, to activities of daily living that we need to remain independent. And when we lose the last of these, in particular the ability to feed ourselves, is when the problems emerge and when people then are required to have care either at home or in a care home. Those are the years we want to minimise. We want to maximise these earlier years with minor problems. We've got evidence, actually, that if you keep people moving early on in this state of decline, you can actually reduce the rate they decline. So perhaps everyone should live on a hillside or on a staircase, because exercise is most definitely good for you. So a reverse question to that is, the great Greek doctor Hippocrates said, that which is used develops, that which not used wastes away. So should we actually be giving people electric buggies when in fact they could walk perhaps a little more slowly than usual, but they could keep walking and keep their legs working? Perhaps a buggy like that is a disabling device. So there are loads and loads of assistive technologies, and you as clever engineers can think of all sorts of devices which might make people's life easier. But let's just remember what we've just been saying, and also remember that these things have to fit the person. It's got to be personally suitable to a person where she lives in their own home, and solve the real problem. Much of these technologies are actually simple things, yet large numbers of them don't work because they don't match to environments and personal requirements. So these are quite tricky problems, even though they're not fancy high-tech. The key thing that happens to older people is they develop what we call long-term conditions. Dementia is, of course, one of them, type 2 diabetes, heart disease, lung disease, and incontinence. These are the sorts of issues that our medical colleagues have to support, not usually in hospital, but in clinics outside, but that's the clinical challenge. At the same time, people may develop sensory impairments of vision, which we're very familiar with, I think, hearing, taste, and smell, all of which have their consequences for independence. As far as dementia goes, then 1 in 14 adults aged 65 have some form of dementia, and it's costing the nation about 26 billion at the moment. There is, however, some good news. Actually, the rate at which dementia is occurring is now decreasing. We think this is due to better living conditions some 60, 70 years ago after the end of the Second World War and so on, but that is what's happening. There is actually good news on that front. So let's just now think very carefully about care. What does it involve? It's the real basic tasks of life of feeding, toileting, which may include incontinence care, bathing and personal care, and of course dementia. So to some degree we can use telehealth and telecare. Telecare, where we can monitor someone's home and see whether they've got out of bed that day, detect whether they've fallen over, have they turned the lights on, drawn the curtains, all those sorts of things. And we can also use telehealth systems where we can monitor people's blood pressure externally, we can monitor various other blood sugars and a whole lot of important clinical variables so that they don't have to see doctors and nurses all the time. When it comes to personal care, are robots the solution? I bet we should talk about robots this evening. A lot of personal care is provided by relatives and friends, and it's very expensive in terms of time, and of course time and money are closely related. Care homes are expensive. because they provide highly personal services, and care home staff are poorly paid. There's a difficult economic conundrum there. Also, we need to remember that loneliness is dangerous. Loneliness kills more people than smoking, older people. It is a very, very dangerous condition. So if we had robots for nursing care, what are the problems we'd want them to deal with? We'd want perhaps help with mobility, issues of incontinence, monitoring people, assistance in living, bathing assistance. We could probably develop all these, but is that the way you want to go? So, what should we focus on? Re-ablement seems to be something we should do, keeping people fit and moving. Maybe we need some other assistive technologies to give benefits to the end of what we call the life curve, when things are starting to get really difficult at home. We want to maintain people's fitness, so we need to do everything we can to enable them to use the environment around them. Over-assistive technologies might be dangerous, might actually increase disability and increase dependence. And care homes will always be required for some people, but I don't think we're sure yet what technology can offer. So, some topics to discuss. Should we be trying to prevent early decline? Should we be trying to reduce the rate of decline? Do we want to provide high-tech solutions for care? Do we want robots for care? Should we be focusing on smart homes where everything is monitored and we can have people in a sort of safe environment? Perhaps we should be thinking about smart cities.
Important to not to forget that the retirement age is increasing. So we're talking about older people working in healthcare as well as an ageing population of patients. And these ageing population of patients are getting more and more complex and having more and more different needs and being treated by more and more different specialists. And we need to look at the needs of the carers. That could be medical staff, or it could be families or other people like that, in addition to the patient. To do this at Addenbrooke's Hospital, we use a method called inclusive design when we're looking at new things to aid with our patients and our staff. And this is a method of approaching design in a holistic manner. We analyse and take into account the needs of all the people that come into contact with the device, whether that is the patient or the user or the person who sterilises it or stores it or packs it or cleans it or throws it away. And we need to look at all of their opinions to create the ideal device. Consumer products function for a population that is generally formed within the normal range. And that's quite narrow. There's a significant portion of the population who fall outside that normal range, and we are looking to provide mainstream devices that people outside of the normal can use. The other tool we use is the Healthcare Design Toolkit, which was developed by the Engineering Design Centre, which is part of Cambridge University. This again looks at the setting and the area in which the equipment is used, and looks at the needs and requirements of the user population. We have a design cycle format, so we collect the needs and understand the needs of those people who are using the equipment. We come up with some designs and then evaluate those designs against the original specification, update our specification with any new needs that we've just realised, and then the whole process starts all over again. And by looking at this holistic view of device design, it's not just medical devices, it can be all kinds of devices, and its life cycle, the users and environment, we can make a much more versatile and much less narrow consumer world.
Thank you very much. Simon.
Well, good evening, ladies and gentlemen. I'm here from Newcastle University to talk about the importance of transport to independent living and quality of life. And I can see from the survey that I've got quite a tough task on my hands this evening. And it kind of reinforced some of my concerns that perhaps transport is overlooked in terms of its importance and its significance. The fact is that whilst actually living at home is obviously the sort of benchmark of independence, transport is really, really important on top of that because it makes people mobile. It enables people to leave the confines of their home and to move around and to interact in society. It enables them to keep a job for as long as possible, and we know that there are going to be pressures on raising the retirement age, for example, in the coming decades. It enables people to nurture themselves physically and mentally, and that actually contributes very positively to health and well-being. If people are able to get out and do things, to perform leisure activities or to meet friends and family, then it's very healthy from a sort of mental perspective. And this can have, albeit quite difficult to quantify, it can have a really positive knock-on effect on healthcare and the costs of healthcare, especially in terms of things like depression, which Garth mentioned. So there are economic benefits to mobility, and there are possible health and well-being benefits to mobility. And the converse, of course, is that if people can't get out and about, they risk being socially excluded, and that has very negative potential impacts on their lives. So one of the things we try to do, not just for older people but for everybody, is inclusive mobility, and we try to look kind of holistically at all the different modes of transport, including walking, and try to work out how they can work as a system as efficiently as possible. Technology has a part to play in that, and it can be a kind of glue to bring together, to stick together all those different transport-related components. It involves a lot of stakeholders because it involves transport operators, it involves government, local government, it involves managers of the built environment as well. So there are a lot of different disciplines that are attached to this. And in terms of technology, we've got static technology at railway stations, bus stops, airports and so on, and on vehicles. We've got technology to issue tickets, for example. But increasingly important is the internet and smartphones. And if you can deliver all the information that you want and all the technology services that you want to smartphones, they're by definition personal, portable, and they enable bespoke, personalised services to be delivered to the user. So this is a really important area that we're looking at. And of course, one of the great challenges is to try to encourage as many older people as possible to use technology, including smartphones. And probably during the discussion this evening, we'll hear about some of the challenges that we face.
Thank you very much, Simon. Edward.
Thanks, Garth. I think you already pitched a lot about the use of technology at home. Daily life at home, when you reach an age, is quite difficult. You get stiffness in the joint, you reduce the ability of your sensors, and then it's become quite difficult to live at home in an autonomous way, which is really important psychologically, and that's where technology could really help those persons which are in need of support when there is not the family close to the patient or close to the habitant. That's where maybe technology could take a part of it. Then it could then help to in the daily life activity to maintain an autonomy. It could help to communicate, to create like social network, like where young people are really aficionados. That could also be projected at home in order to maintain a social communication in between people in order to fight against the loneliness. Also to bring a close connection between home and the health system, because a lot of information could be gathered already at home in order to maintain a link with the stakeholders. We could then monitor remotely the people at home in order to optimize this relationship and then bring the people in need at the hospital or at the stakeholders just when it's needed, which might then reduce the risk of any event that could happen during the transport, even if the technology get better on the transportation, but could help then to reduce the cost as well by focusing on the people which are in need. It will also help to secure the home environment, because when there is, for example, a fall, unfortunately it happens that people could lay down for 72 hours before having emergency service arriving at the to give some help. So that's where technology could help in order to detect such kind of events, in order to alarm the stakeholders or the family. And also, what is very interesting, technology could help to motivate in order to keep a physical activity to the habitant, in order to keep a good health condition, because it has been shown, and every day there is new information about it. If you keep an activity, then you keep in shape. And that's something that indeed could improve the quality of life, because that's one thing very important. Medicine might have extended the lifetime, but now the new challenge is to expand the quality of life for the maximum of the time. And home is a very important time where we spend a lot of time, so if we can improve it with technology, that's something that could be helpful.
Thank you very much. Isaiah.
Thank you. Good evening, everyone. So I'm sitting in the corner of community providers, and I believe greatest emphasis should be placed on the community provider. The interpretation of that which I've been given is as a medical device engineer or a medical device provider within the orthopedic community. So I think medical device engineers, they are responsible for a lot of innovation, developing cutting-edge technologies for healthcare. A lot of the developments they have require resources, but are also very critical to improving life for an aging population. I think the question is, how can we better support life, independent life for an aging population? And I think a lot of the technologies which do that have already been realized. So everything from data-driven wearables, IoTs, electronic healthcare records, electronic prescriptions, medical robotics, computer-assisted surgery. I think the list is quite elaborate. All of that, a lot of that comes from medical device engineers, particularly from orthopedics. I think like any other technology development which are at its early stages, there are barriers and there are issues which need to be overcome. Some issues, for example, are the lack of trust from healthcare providers towards the aging person or the elderly people. There's also a lack of trust from elderly people towards technology providers. So these are really big issues. You then have issues of how do we protect and secure people's private data, people's medical data. So a lot of these challenges and these barriers need to be overcome, and I think it requires support from governments, it requires support from policymakers. So yeah, in my opinion, I think there is still a big gap which exists between the changing expectations of technology users. So one technology may be effective at meeting a user need, but then it doesn't necessarily guarantee user satisfaction. And I believe it's the latter which we need to focus on and concentrate on. That requires the medical device engineer to go away and to think about and to create better solutions, to think about and create better products. So yeah, I think once again, how can we support independent life for an aging population? I think the answer to that is to keep up to date with user needs and with user preferences, using state-of-the-art technology, which can be provided by the medical device engineer. So.
Hi, I've got another question for Dr. Edwards. Sorry. So you mentioned in your introduction speech about moving on to smartphones and the focus on iPhones and how that would help people. But we heard in the introduction about how sat-navs and technology like that actually can affect people negatively and be debilitating. So I'm just wondering how that would differ, and obviously we heard about the taxi drivers' brains and how you think, if you think there's a point when at a certain age, then it doesn't affect your brain more and it's helpful, or?
It's a good question. I think the specific type of skills that sat-navs sort of complement or substitute, if you like, are maybe ones that GARTH suggests actually degenerate if they're not used. I don't know whether that's the case with the type of functions that smartphones provide. Smartphones and other types of technology that enable people to interact with other people in a sort of, whether they're using the phone function or social media or whatever, or they're actually using it for apps or for travel information, which is the very big thing that we transport professionals try to promote, has a really important role to play, I think. And I don't think that will actually lead to the decline in any particular abilities, if you like. It actually enables people to develop new ones in some respects. And I've talked to older people who actually like certain technologies and like certain apps. Older people seem to love iPads, for example, and tablets. And I suspect that's because you combine portability with a big screen, to put it simply. Now that's a really interesting finding. So I actually think if it's done properly and carefully, the technology can actually help people develop new abilities.
Helen, I think, has a question from Twitter, no doubt.
Well, actually, I have my own question.
You have your own question? As long as it's not to Simon.
No, well, actually, it's to all of the panel guests. Recently, the Institution of Mechanical Engineers has been looking at the issue of bed blocking or delayed patient transfer, and how do we get patients who often are older patients out of hospital, out of the clinical setting and into a more social setting to enable them to get better more quickly. From each of you, I'd just like to ask, what do you think is the best way of dealing with that, and in your own sort of specialist areas? How do you see us overcoming the issue of bed blocking amongst the elderly?
I'm going to ask my colleagues on my left here quite deliberately too.
That's a good question. I know it's certainly a big problem in hospitals. Something, I guess, from my perspective, which I think would be worth introducing, a couple of things actually. One would be use of electronic healthcare records, but I don't know how far down the line we would need to wait before a patient can be dismissed and can use that. The reason I say that is because electronic healthcare records, they allow elderly people particularly to be able to store and collect data whenever and wherever they are, and for as many times as they want without the need for expensive consultation. So being able to keep an eye on their own vital, so with healthcare monitoring, you looking at the vital statistics of a patient, and that's a lot of the time they're in hospital after treatment because they need to be monitored. If we can have things like data-driven wearables, which enable healthcare monitoring to occur remotely, then that could help them dismiss patients, so that patients can record and send and transfer their own observation, their own physiological signs to the hospitals.
One thing which is important, in order to continue what you just say, is also in the thought of the patient. In fact, if he is dismissed, one point which is important is will he be fine? One of his questions is, okay, I go back home, but am I secure at home because I just have health care, I'm recovering. At home there won't be the nurse, there won't be the doctor, there is nobody around me if there is any problem. And also, how could I know if I'm recovering or not? And that's where indeed the data which would be gathered could maybe secure the patient when he would be back home. Like, no, don't worry, you will be still monitored, we will be there, connected to your house in order to be here if you are in need. And also help the patient to maybe by himself see how he recovers. So keep track about, okay, am I getting better? Oh, yes, my temperature is getting lower if I got a fever, or my other information monitored are getting back to normal. So like that, he could also see by himself that he is getting better. So the question is, how could we help the patient to go back home earlier or in social communities? It's monitoring, but also it's reassuring the patient that he will be safe.
So our users in this context are older people themselves. They're people like me who are old and might need services to enable me to get around and so on. Do I have a question from that perspective of the user benefit of these different technologies we've been talking about?
With the increasing use of telehealth and telecare, do we get to this point where we almost it's too efficient, the treatment that is being done, that elderly people become isolated because they no longer have to go to physio to get rehab or go to doctors to see them weekly or however often they need to? That's directed to any of you who...
It sounds like you're describing a healthy person there.
No, so with all the remote monitoring, is there almost a point where the elderly become really isolated because they no longer have to go to the hospitals often and they can just stay in their houses and be monitored in that sense?
They are. They're already lonely. There's already people that don't see anybody for multiple days at a time. And yes, I think by reducing the number of people like maybe health visitors or Meals on Wheels even, you are isolating them.
But doesn't that make it dangerous for their health? So they are more independent as such, but is that actually good for them?
No. They're not having contact with real people. They're only having contact with robots, as GARTH mentioned in his opening. I think we all need human-to-human interaction, and the radio and the television are wonderful, but if I shout at my radio, it doesn't shout back to me.
This is actually a good point, and it doesn't just cover healthcare, it covers many different functions in society and tasks that people have to do, and older people that we've spoken to, for example, talk about banking, and they won't do internet banking, partly because they're worried about the security, but also because they like to go to the bank and talk to people, talk to their friends. It's a social event. So when you factor in the sort of mass closure of bank branches, and we've seen Lloyds are doing that just this week, you're creating a new problem, because older people actually do want physical contact with real human beings.
I'll just interrupt and say, I think that is a very fair comment to say that they'll be missing human interaction, but you need to go back and think about the benefits of data-driven wearables, because what about the elderly person who is at home and very mobile, very sedentary? They're missing consultations because they're finding it so difficult just to move, just to get out and go to the hospital. I think so there's an underlying benefit for that sort of demographic, for that sort of elderly person. It's not just, they're missing interaction. I think there could be other ways of providing human interaction without removing good technology.
In fact, it's a question of balance, because in a way, healthcare system is not a social place. Maybe we could secure people by monitoring, but also improve by securing the transport, by securing them at home, improve them to contact elsewhere, to go elsewhere, to move, rather than having the ward as a tea party. And that might be much better if they could decide themselves where to see, rather than indeed having their meetings appointed by the social system.
Also, just as a short aside to that, I think when it comes to healthcare technology, data-driven wearables, remote healthcare monitoring, I think a lot of the times we as humans are presented with something new. There is a period of learning, and I think that keeps us alive as well. So when it comes to giving an elderly person new technology such as that, there will be a phase, there will be a transition phase where they're getting to learn things, and that in itself could be what they need to stay excited and happy about life. So.
Quite an interesting, as chairman I shouldn't be making these comments probably, but quite an interesting little thing that goes on about whether people get out and about. bus passes come into action at 9:30 in the morning. There are, right across the UK, there are 9:30 bus clubs where people who have bus passes go for the first bus, and they all meet each other. They go and have a coffee, so on. This is quite a simple bit of technology, really simple bit of technology actually, which can influence social behaviour.
I like to hear all these optimistic thoughts, but I think the reality of the matter is that people, as they get older, especially into their 90s, are deteriorating, and that their ability to use all these fancy gadgets and wearable devices and iPads and so actually decrease. And in the end, they can't even use a simple phone anymore, even with big switches. So are engineers taking that into account, and are you thinking about adaptable devices for people who are dementing or people who are getting older and whose abilities are actually decreasing and deteriorating, to keep them at home as long as possible? I like to hear you that people can learn new things, but I think the reality is that if it's too difficult, they don't.
Do I have a response to this slightly gloomy remark from Catherine?
It's also the work of engineers in order to adapt the usability of the device to every strat of the population and to think about it. And that's where there is something which is very important for engineers, is to gather with medical stakeholders as well as with patients or users. That's very important to connect all these different persons all together in order to discuss, because we might have, as engineers, a bright idea, but if it doesn't meet a need or if it is not well presented, then it will be useless. And unfortunately, there is a lot of prototypes which are very interesting, but which, unfortunately, by not meeting the needs, fall apart.
I think, just if I can add to that, I think it's really important not to isolate the situation too much, because the aging population is quite vast. The people who are 65 are more active and can do things people who are 90 years old cannot do. But I think as a community, with a holistic approach, that's where something like Life at Home, people who deal with occupational therapy, that's where they could be helping, where technology doesn't quite reach a certain age. There is another community for that, who can deal with people who are 90 years old and 95 and at their dying stages of life, because what they need will be different to what someone who's 65 or 70 years old might need and want. So.
And also we might think about, recently we heard about artificial intelligence will get more and more intelligent, and the thing is, maybe it's to the technology to adapt to the user somehow. When you see that the user is not interacting with the system not enough, maybe because the system should thought that it's because it's not usable, and then adapt to the situation.
Yeah, so there's adaptable technology.
Last comment on this,
that people can tailor to their own needs, and there's adaptive technology that sort of fits with the needs of the older person based on their use. So I think it's very important. And I'll just add that I think it's probably the role of engineers to try to have an approach of participatory design as far as possible, where they involve older people from the start of the design process.
Thank you, Simon. My next heading is cost. This is one that will really get everybody going. Can we afford, all you guys have got these clever ideas, can we afford them? Are they cost effective? So do I have a question from the audience?
I'd actually, from a healthcare provider point of view, I'd like to ask Nicola, the cost of the last 6 months of life is the most expensive, particularly for the NHS. What sort of technologies do you think are available now, or could potentially be available in the future, that could reduce that cost and that cost burden on the taxpayer?
Okay, I'm going to tell you about a personal experience. I lost my mum to cancer about 18 months ago. And she loved being outside in nature, in gardens, and the last month of her existence was in a hospital trying to count pigeons out of the window of her hospital room. And more recently, I am involved in looking at technology that's going to be used in research studies within the hospital I work in. And they were looking at using virtual reality to build, say, a garden or a walk through the forest or other natural environments where you could put on a virtual reality headset onto a patient. And the results that they were having with this headset were marvellous. People were relaxing, their blood pressure was going down, their symptoms of depression were improving, their mood was improving, and that would have made such a difference to my mum if she'd have been there. It doesn't really cover cost because virtual reality is really quite expensive. Developing the software, again, would be quite expensive, but I think the quality of life benefits to the patients would be tremendous.
Do I have another question about cost?
So obviously cost is very important, and you guys are all involved in developing new technologies and new approaches. So if I were, and I'm not, a very wealthy philanthropist and I wanted to invest £1 billion in each of your areas, what would you spend it on, and what step change would you like to see made by doing that research or developing that process? Or what would you do to make a big difference?
There we go, there's your challenge, guys. That's what they call the killer question.
One big thing that keeps patients in hospital is falls. So there's a whole wide range of reasons why people fall over. Sometimes they trip, sometimes they kind of collapse, their blood pressure drops, and so do they. They can fall getting out of bed, fall transferring between beds and chairs. And so if we could spend that £1 million on reducing the number of falls that happen either within care homes, within hospitals, or within the patient's own home, it would prevent the damage, the physical damage to themselves, and it would also prevent the mental damage that happens when you fall over and you lose the confidence to move around your own environment.
Okay, more, come on, how are you going to...
I'm from
rich investor going to invest in you. What are you going to do?
I'm from orthopaedics, so I'm going to give a biased perspective. I totally agree with Nicola. The increasing number of falls in the aging population is expected to be one of the five biggest challenges to the American healthcare system coming up. I think 1/3 of people who are 65 years old and above will suffer a fall, and of that population, 20 to 30% of them will have a hip fracture or severe injury. We need technology, not just to try and prevent that, but to rehabilitate that. And so something which I would invest in is use of CT scans, a replacement for CT scans, which are very, very expensive for patients who've had surgery, and they're not always, you can't always use them, they're not always available. More recently, medical engineers have been looking at advances in ultrasound imaging, which is a far cheaper alternative. And so if there can be ways of imaging, viewing patients' bony defects, for example, using an ultrasound technology as opposed to CT scans, that would be a major cost to the healthcare system. That's something, a very biased orthopaedic perspective.
Edward, how are you going to spend the money?
Still about falls. Apparently it's a major subject. The thing is, there might be two ways to fight against the fall. First, one of elements that participate to the fall is the fear of falling. And when you are afraid of falling, you might fall more often. And the thing is, maybe I will invest this pound, or maybe several millions of it, because that's what might be needed, to improve the research and also the technology on first fall detection with every different system like accelerometer, like depth camera, like the Kinect, which allow to keep the privacy of the habitant. in order to, when the fall occurs, the person will be reassured that the emergency services will be alarmed and will come. So that's the first point. The second one is a new system named Exagaming is rising a lot actually. That's using the new gaming technology. I'm talking, can I say brand or not? Yeah. So yeah, let's start to PlayStation with Sony, to the Xbox from Microsoft and some others, to use this low-cost technology to help the patient or the habitant to move. Because if we can keep the patient or the habitant with the correct balance or with the correct muscle activity or get used to move, we might reduce the fall event. And that might be something which is at the beginning of all the fall treatment, which is kind of costly with the surgery, but also with the healthcare just after. And maybe we could avoid people to get through the NHS like that.
Simon.
Well, I'm going to cheat by not investing it in engineering or technology, because remember I described technology as the glue that binds together transport infrastructure and networks. I would invest it to subsidise unprofitable public transport routes, because remember most public transport in this country is run by the private sector for a profit, and unprofitable routes are always at risk of being axed, which can actually lead immediately to levels of social exclusion and isolation, especially amongst rural populations, and very often they are older populations. So I would be doing my utmost to make sure those people on those at-risk routes still had access to the transport network in some way, shape or form to enhance their independence and quality of life.
We're now on to ethics. That sounds a good hot one for debate. Yes, please.
I spoke to NICOLA earlier on about medical devices and how they're ethically created and where they come from, the economics and the environment about devices. You know, when we talk about recycling them and that kind of thing, what can we do about that in terms of the way they're ethically recycled and used in that respect?
Okay, so it's a question about sustainability of provision of devices. That's
correct. And as our aging population moves on, the likelihood of the device's lifespan, along with those devices, are they used more, created more frequently, are they designed for a longer duration, and how are they recycled, and how are they used or designed for a longer life cycle, for a more sustainable use?
That's a lot of questions.
It is a lot of questions.
I think that in terms of sustainability, how can we reuse implants, for example? Depends what it's made of. If it's made up of metal, if it's made up of plastic. So, yeah, I guess that's what I would say to that. I mean, not everything can be used again. Plus, we need to think about the fact that technology isn't a static environment, it moves on. So the technology we use today may not be relevant tomorrow, in a year's time. So unfortunately, those materials, those implants, those devices, they may have to be parked aside in place of newer technology which is taken over. So not a very hopeful forecast, but that's just my perspective on the issue.
Edouard, do you have some thoughts on this?
Yeah, particularly about more and more medicine might become personalized, which means that every equipment might become custom-made for each patient in order to really fit to the patient, which indeed makes the equipment then not reusable because it might not fit to another patient. When we are talking about an implant, already some implants are built on the shape of the patient, and indeed they could not be used on another patient. But after, it's also a question of regulation, and that's something very important, particularly when we begin to talk about ethics. If the regulation is correct, starting from the design, the recycling question might be part of the design question, and then that's something that could make the system maybe broken apart after the use in order to be put back into the chain during the production chain, in order to reduce the cost of the production at the end, but also keep the safety level, because you might not appreciate to have an implant that have been already used before. You might prefer having something which has been built up anew. So there is different aspect of this question, but indeed you're right, for the ecological questions, that's important to recycle.
Can we finally, the last thing on our list is that of technology push or pull. So who's deciding on these technologies? Is it older people who want the world to work for them? Like, I'd like to have railway tickets where I can actually read the destination and the seat number on the railway ticket. That's my technology pull. Or are we in danger of creating a world in which all you clever engineers create all sorts of things that older people really do not want forced on them? How do we get that balance right?
Somehow I wish my dad was here, because I talk to him every day, and his fight is not to go into hospital, but to be cared for in an independent way. And he would definitely have a say around that, and that, I think, would be his comments around the kind of discussion you're having.
How do you get this balance right is what the question's about.
You ask the people what they want.
How do you... Pardon me, I shouldn't be phrasing the question, but what do you mean by that? Because that's quite a complicated statement in itself.
You look for unmet needs within a patient group, and then look at how you would meet those needs, either with technology or with processes or possibly with drugs. Or at least that's how I'd go about it. How about you?
Well, in the transport industry, a lot of the technology is a kind of top-down approach, infrastructure, systems-related technology, and it needs to be designed very carefully to make sure that as many people as possible can use it effectively. So I would again recommend a kind of participatory design approach involving users of all ages at various phases of the design and development and trialling of any technology. I would also, again, come back to portable smartphone-based technologies and make sure that they can be adaptable to the needs of the individual, so that they're not having to wade through loads of functionality that they don't want to use, so they can just quickly access the functions that they do want. I would also be talking to engineers or software developers or whoever about upgrades to systems, because older people hate it. Most people hate it when things are upgraded and changed completely. Windows 10 was an example of that, but it's a major issue, because all of a sudden something people have become familiar with using for maybe years, they suddenly have to relearn it, and that can be a big effort, and it can shatter people's confidence. So that's a very major area that needs to be addressed as well. Over functionality, learning, upgrades, and bespoke technologies as far as possible.
Can I just add one thing to that?
Yes,
just
please.
Quite simply, one way which I would try to alleviate that problem is this. As engineers, by definition, we are supposed to be problem solvers. I think any technology that's made should start with a problem. At least this is how I tend to operate. I mean, you have a problem, you look for a solution. But what people are doing are creating solutions for problems which don't necessarily need to be solved. So I think one way around that issue of technology push and pull is to start whatever project you're doing, start with the problem, define it, make sure it's well articulated and it's clear where you're going, and that there will be an end goal, you know. So yeah, it's one way around it.
So now our final stage of this, before you can all vote again, is that each of our speakers, our 4 speakers tonight, has the opportunity to make a brief closing statement. You have 2 minutes each, my colleagues on the table, to summarise where you think you've got to. You've probably been influenced by the questions that have been bandied around today. You have 2 minutes to state your claim for why your field's important. Nicola.
It's Difficult going first. All of the members of the panel have talked about looking for what people want, rather than trying to create a thing and then find a niche to fit it into. I think that's really important when we're looking at older people. They don't want to be forced into boxes or forced to do things that they don't want. Also, an older population there's multiple generations in an older population. It's not just old and you kind of fit in this box. In some old people's homes, there's multiple generations of the same family. So we're talking about a wide range of people with a wide range of abilities or disabilities. And unless we realise that, I think we're barking up the wrong tree.
Thank you. Simon?
I think all 4 areas are really important, and they shouldn't be. I know you have to vote for one over the others, but in reality, they're all really, really important. And I think they should be more interlinked. And I think there's a risk that we just drift into our own silos. We should work together more. I remember working on European Commission-funded projects around a decade ago, where they tried to build up massive projects which integrated all these areas as much as possible. And they were bloody difficult to manage, and they didn't produce the results they should have done, but the effort was there, and I think that maybe has been lost. So we shouldn't be just talking about transport in isolation. It has to be linked with other particular areas of engineering and research and development to benefit society as a whole. If I had to make some key recommendations in the transport field for older people, I'd say personal portable technology is very liberating, and it can be user-friendly like iPads, and it can be tailored to the individual's needs, which is great. I think engineers need to have a more participatory design approach where they work with older people right from the start and produce stuff that is easy to learn and easy to use, and to try and avoid unnecessary functionality and unnecessary upgrades. I think traveller information is the #1 concern for people on the move. It has to be real-time, it has to be reliable, it has to be up-to-date, it has to be accurate, and it has to be multimodal so that people can make a complex journey, because in reality you use lots of different modes of transport. And now in transport we're talking about something called mobility as a service. So we're not thinking about modes of transport individually, we're thinking about them as a whole and how people move between them. So that's very important.
5 more seconds.
Okay, joined up stakeholder engagement, because there's a lot of stakeholders involved in all these different areas, and training, which is a low-cost solution, but it really helps people learn to use systems or transport modes and become confident.
Thank you. Edward?
I will follow your lead. I think that every domain needs to be improved. Transportation, healthcare system, and also home, but equipment as well. I hope that every domain will have the same percentage. That might be difficult, but that's very important, because you can't live happily at home if you can't move. You can't live happily at home if you are afraid of getting to the healthcare, which is not correctly funded and efficient, and you can't be at home if you don't have the technology to sustain it. Indeed, it's important to feel safe at home, because that's the place where you spend a lot of time and the place where you rest. And yeah, home is important, but home is just one place connected to others. So it's important to improve every aspect of the life in order to keep the person autonomous, which is one of the biggest part of the quality of life.
Thank you very much. And Isaiah?
Yeah, so I think a recurring theme in our talk today and debate today has been the use of digital technologies. I think digital technologies have made a huge impact on a number of sectors which affect our lives, so from transportation to communication, entertainment, all apart from healthcare. And we need to ask why that is. I think today you've heard for yourself that it's not because of a lack of innovative ideas from medical device engineers and other sectors. It's because we need support from policymakers, we need support from governments, more funding and more support from regulators to overcome some of the really strict standards which they've set and put in place.
It's now the opportunity for you all to vote again and see how our speakers have managed to influence your views. So you now have the opportunity to press your buttons.
Wow.
So nobody wants to pay the national health care. It seems to be a trend.
That's very interesting. Is that what people expected to happen?
I have to take the opportunity to say thank you very much to GARTH for chairing this evening. And from my point of view as well, I actually failed to introduce myself properly at the beginning. I'm head of healthcare here at the institution, and it's my responsibility, as I pointed out, to help make those policies and try and drive policy forward. One of my responsibilities is to try and encourage the government to develop policy and strategic plan to enable us to have better provision, particularly for older people, but for healthcare in general. So for me, this evening has been a great opportunity to hear your thoughts and to hear the views of some experts in the field. So I'd like to thank as well the speakers for what's been really an educational and very thought-provoking debate. It's clear that certainly our young engineers have a real passion to address these very important issues for our older generation, and indeed finding solutions is pertinent to us after all, because we're all getting older. You may not think it yet, but you'll get there. And I certainly believe that I will feel much happier in my old age thanks to the commitment and innovation that has been expressed here this evening.